as Douglas said, my name is Erin, and I'm an NSWAC and clinical specialist for Coloplast. I'm really excited to be moderating today's session. It's titled Simplifying Wound Care, Progress You Can See. This presentation is going to walk you through 2 recently published studies that we believe could have an impact on your wound care practice. Our speakers today are Patty Markey, lead medical specialist for Coloplast, Jason Lau, NSWAC for Michael Guerin, Toronto East Health Network, and Jordan Smart, CNS and NSWAC for Seniors Health of Assisted Living, Alberta. If you'd like to view their full bios, please check out the Wounds Canada app. With no further ado, I'm going to hand the mic over to Patty to get us started.
Good morning. Can everybody hear me okay? You've heard from a Scotsman, you've heard from a Welshman, now you have to hear from an Irishman for the next 20 minutes, so complete the Celtic triangle. So it's delighted to be here again. I'm just going to make sure the slides are working. So actually yesterday I was on a call with a member of the EWMA committee, and EWMA is the European Wound Management Association, and he described when we were having a conversation about the EPIC program they're running, was a description of the World Health Organization of the state of chronic wounds as being an epidemic. So that will probably resonate with many of you. Oh, before I start, I have to go through these slides. Apologies. And here we have our speakers, who Erin has just mentioned. But this is the slide I wanted to start with. So this will probably resonate with many of you and some of the things that Professor Harding and Douglas talked about earlier. I described them in 3 areas: the workload, the workforce, and costs. Because we have seen, and you will all experience in your own practice, the increasing workload you have for every complex patients, the comorbidities, and the volume of patients you are seeing. And when I talk with my colleagues all around the world, the consistent thing that when everybody talks about wounds is the workload, the pressure on the workforce. When I was here last year, we talked about the number of vacancies that exist across the Canadian healthcare service and nursing. That is similar challenges around in Europe as well. And increasingly governments are pressing for cost improvements because there actually is no money left in the system for additional spend to manage wound care. So the 3 areas, hopefully over the next 25 minutes or so, and this session will provide you with some insights, some results of the clinical evidence that hopefully you can take back into your practice to help simplify and manage that balance between workload, workforce, and costs.
Yeah, so I think everyone in this room can probably agree that they've experienced some form of challenges when it comes to workload, workforce. I know for me, for community, increasing complexity of patients and working short was very common, as well as a high turnover rate of staff, and that can add to just the challenges of an already complicated healthcare system. So we'll start with Jason. What is your experience with, what's your local experience with these challenges?
Wow, I'm not even going to start with the distribution challenges we've had over the last 1.5 years. But what Ontario Health at Home has done over the last probably 5 years is the clinic approach. So a lot of our clients have been kind of, unless they're palliative, actively dying. Did I just lose? Okay. Or they can't transfer to a treatment bed, they actually are encouraged or literally forced to go to the ambulatory clinics. So there is a reduction of nursing visiting for them to support. And it's very challenging, especially if it's a wound that we need to pressure offload. And what breaks my heart is when I worked in the ambulatory clinics, a client could be coming for just a simple venous ulcer, and on their way, they sustained a fall, and they've developed multiple wounds. So it does break my heart. What I'm seeing is a lot of novice nurses who don't have that concept of a wound care best practice, and they haven't grasped that yet. So they kind of are struggling in using, knowing what antimicrobial to use. And in terms of distribution, as someone that does a lot of discharges for community follow-up, I'm constantly navigating with the care corners because they don't have what I'm recommending. After alternatives and alternative suggestion, what do you want? You're not accepting wound care best practice. You want an actual order, but you don't have what I have or what I'm requesting. So That's what is really frustrating for me.
Yeah. Oh, sorry. I'm getting over a cold, so I might squeak. I'm not going through puberty. Just bear with me. Yeah, I just want to echo what Jason and Aaron have said. Just the workload. I mean, I work in home care primarily, and just seeing how people have, for some reason, are starting to access healthcare a little later and trying to delay that access to healthcare. So people are coming in with more complex issues and more, comorbidities and a little bit heavier. And I'm from Alberta. Is there anybody else from Alberta in here? Yeah, there's a few. I mean, I'm from assisted living Alberta. We're not Alberta Health Services anymore. And so just there, the distribution, it's all been broken up, and trying to figure out who we are and what we can do. And within that, just the workforce, for some reason, the workforce has also just started to leave, and there's so many vacancies. And so with our decreased workforce and the workload going up, it is becoming more and more difficult. And as Jason said, having novice nurses come in and not understand wound care, sometimes they don't even know when to access the right expertise and ask the right questions. And because for some reason, it's just part of the process, right? And so it is a challenge to provide, good evidence-based patient care when the nurses aren't even, putting in the referral for an expert to come and talk to them. And so, yeah, it is becoming more and more difficult.
Thank you. From an industry's perspective, I just wanted to share this slide, which represents the hierarchy of evidence. So from certainly around in the European markets, and we see it more in North America as well, we are being asked to provide more robust, stronger evidence, and evidence that is higher up on the hierarchy triangle. So I'm happy and really delighted today to share the results of the randomized control trial we have just published from work in the UK, as well as an observational study that was from work in France. So I'll start.
Oh, okay, perfect. So Jordan, how does evidence inform your practice?
You know what, this is probably one of the most important things for me, because when we have evidence, especially good evidence like a systematic review or RCT, that provides kind of a standard of care that we need to try to establish, and that we need to try to adapt to our individual patients. The nice thing about having that type of evidence as well, it can give me confidence and trust in that the research that has been provided is accurate, and it will actually provide us with hopefully the accurate results that we need. It's important to do this. I mean, no matter how much we love expert panels and everything, those are still just people's opinions. Now, granted, it is for a long term of experience throughout their lives and throughout their career. However, it's always nice for me being a numbers guy to have the numbers to back up what I'm doing and how I'm doing it, but also be able to individualize that to the patients that I take care of.
Well, as wound care clinicians, we strive, to provide evidence-based practice because it gives us the confidence. I'm sure Jordan and I would agree that the suggestions and recommendations we provide will achieve optimal wound care healing outcomes. But I want to pull you back, that wound bed preparation paradigm, what we strive to kind of, use to support our clients, patients, or residents, regardless of the setting you're working in. As much as research focuses on a lot of variables, the most important variable is your client. And you have to use your judgment as a clinician, looking at all those elements and, determining what is best suited for them in terms of, achieving that healing outcome.
Okay, thank you. Let's start with looking at some of the evidence that will hopefully help you simplify your wound healing practice. The first is a published paper back in December 2024 in the International Wound Journal. It's available as free access online. But the story actually starts a little bit further back, about 5 years before that, when I was working in the UK and Ireland, and we were working with a group of clinical experts at our advisory board. And we started initially looking at how we could address the issues of multiple dressings being used in typical wounds. And the first paper was published in 2019, and then there was some further work published in 2020. But what it looked at, though, that work looked at about 137 patients. And 84% or 80% of the 137, so 60% of those patients were being treated with 2 or more dressings. And that's led us to look at how could we address the issue of the standard of care, where typically a filler, whether it be an alginate or a hydrofiber or gelling fiber, was used and a secondary dressing. And how could we clinically look and address this issue? So the full protocol available is you can see on clinicaltrials.gov, but what we looked at was a 2-arm, open-label, stratified, randomized controlled trial, comparing Biatain Silicone versus the standard of care. And in this case, the standard of care was Aquacel Extra Hydrofiber as the filler and Mepilex Border as the secondary dressing. So we wanted to show whether the clinical efficacy and compare versus the 2 arms of the study. So again, you can see the full protocol online, but a few key points we looked, as is probably very common across most wound care studies, we decided to select VLUs and diabetic foot ulcers that had a duration of 8 weeks and no longer than 24 months. They were all looking at non-infected wounds and wounds that would normally require a filler and a secondary dressing due to the exudate levels. Any compression therapy or offloading was as per local best practice, and we recruited 102 patients across 10 different centres in the UK. So it was quite a good geographical spread across the UK. We were only looking at wounds up to a depth of 2 centimetres, and we were looking at an evaluation period of 4 weeks. So the primary objective was to demonstrate that the clinical performance of Biatain Silicone was comparable to that standard of care. And there was also a secondary dressing to look at the cost effectiveness as part of that study. So again, as in many cases of published articles, you see the primary endpoint we decided to look at was wound area reduction. So looking at the percentage wound area reduction over that 4-week period. And then because in the UK we have access to publicly available costs around the drug tariff and reimbursement costs, we could look at a total treatment cost during that same investigational period, looking at the volumes and price of products. So the baseline characteristics are very common. I think on average you can see it's nothing really that stands out. Possibly the gender split is slightly unusual. When you see lots of leg ulcer studies, it might be the ratio is the other way around, but in this case there was a higher proportion of males and females. The BMI, nothing unusual there. The average BMI for information in the UK is about 26 or 27, so slightly above. But then when you look at the actual mean wound age and the wound depth in particular, many wounds that we see are actually quite superficial, and yet there's a standard of care of a 2 dressing regimen used on quite shallow and superficial wounds. So the actual results itself, when we saw, you can see on the right-hand side, so over that 4-week period, the wound area reduction for the Biatain Silicone group decreased by 54%, and the standard of care was 43%. So although there was a variance of about 11%, that was not statistically significant. And then when we look at other exploratory endpoints, such as wound depth reduction, we see a similar mean difference with the Biatain Silicone group was 72% reduction over the treatment period versus 60%. And again, that was not statistically significant. Well, this was a non-inferiority study, so we were expecting those type of results. Some of the other exploratory endpoints that we looked at, which is probably worthy of further investigation for future trials. Anecdotally, we hear a lot about the condition of the peri-wound skin when we talk about silicone foam dressings. So there was a question asked, which is slightly unusual, but it's stated here, the proportion of peri-wound skin assessed as nothing abnormal after the 4-week period. So the Biatain Silicone group showed an increase of 24% versus 14% in the standard of care group. So really exciting and interesting results, and this is something we probably will try and investigate further in the future. So if we look at the secondary endpoint around the total treatment costs, we saw that there was a 47% reduction in the number of products used. So the average mean number of products in Biatain Silicone was 5.6, and for standard of care was 10.6. So that actually represents a 33% cost reduction, which was statistically significant. Now, the prices are quoted in GB pounds, but I have written down what the equivalent here is. So £14 for the treatment of Biatain Silicone, I think, is about 26 Canadian dollars versus 40 Canadian dollars in the standard of care group. But the significance here is the statistical significance found in this part of the study.
Great. Thank you for walking us through that study, Patty. I think what resonates with me the most is the product reduction. So I came from a community where we did use a two-dressing regimen quite frequently, and we saw a lot of waste in the home care. And due to infection control reasons, we often had to throw some of these products out if they weren't effective or the condition of the wound changed. And sometimes it really felt like we were just kind of throwing money in the garbage. And so it's really nice to see a study that supports not only a comparable clinical outcome, but is also going to reduce that wastage that we see in practice, that is possible to reduce waste in wound care while also being cost effective and clinically effective as well. So I want to ask Jason, what endpoints from the study resonate with you the most?
Wow. 33% in reduction of costs is definitely, a highlight. I like to invest in wound care. I do believe that you need to invest in wound care, but it's been quite challenging, especially with limited resources and budget constraints. And I echo Aaron's, discussion on the wastage, because I think what happened is over the past year and a half, nurses have been, I don't want to use the word hoarding, but they're ordering a lot more because they're afraid that there may be another distribution or out of stock shortages. So they're having a lot of antimicrobials on hand, which is really unnecessary, because when I just recently consulted, I just saw probably close to, maybe $6,000 worth of dressings that were just not necessary and were just a waste, because most of them was not what I would recommend. And then the improvements in terms of over 70% in healing rates or progression to healing rates is actually what's amazing for the area reduction in terms of wound area and depth. And nothing is more frustrating when healing doesn't progress, because, as nurses, we follow the nursing process. We want to be able to evaluate our interventions to make sure that they do work.
No, and I just want to echo what Jason and Aaron have said as well. I mean, it's the cost, right? I mean, no matter how much as clinicians we don't like to think about cost, we want to think about the patient. It is always getting pressured on us to think about the cost. And even for me, like I've run the numbers for me in Alberta, and it's about 1/5 the cost if we did a comparable study here. And so to be able to save 80% within using multiple compared to just using one dressing versus using multiple dressings is huge. And also the waste. I mean, just like Jason, I've gone out to consults and I see, the patients could literally stock the local pharmacy with how much stuff they have, right? Thousands of dollars worth of dressing supplies. And so, it simplifies, what the clinicians or the nurses need to take out to the patients, right? It simplifies the dressing change so that, even the patients can do it themselves. And then, with the inferiority study, it's nice to see that, you can, kill one bird with one stone rather than two. So, it's always nice to see that, it's comparable to what we do consider the standard of care, and that, has been primary practice for so many years. And so this RCT really did a great job of exemplifying that, or bringing that out, of saying, hey, there is an easier way and a more cost-effective way of being able to provide wound care within your practice. And so that was really awesome to see.
Can I ask just elaboration on what you see normally as standard of care across your practices?
Well, say that again, Patty?
Your standard of care that you see in Alberta, is it a frequent occurrence?
Yeah. I mean, the standard of the care that was within the study. I mean, I don't know if I'm allowed to say this, but we use Mepilex, right? I don't think anybody here doesn't, right? And so, and also Aquacel. Those are two very very good dressings that we should be using. But we also need to use our clinical judgment and say, hey, is this the appropriate dressing for this patient at this time? And so, yeah, that's what we usually see with our standard of care, yeah. So.
Okay, thank you. I'm going to move on to the obviously the next part of the study, which is information around the large observational study in France. So this again was conducted and published earlier this year, so in August, actually, 2024. Now, I'm going to try, as I'm in Canada, I'm going to try and practice my French, because you probably want to know what the VIPS study is. So it's the Observatoire en Ville du Play Exudative. I think I've got that right. Well, it was a large study conducted in the community setting in Paris, and it looked originally at two dressings. So we were looking at the performance of Biatain Silicone and also Biatain Fiber. But what we were looking at particularly here was a subset of that study. So we saw that 64 patients were using Biatain Silicone as part of the study, so we published that as a subset. There was the original epidemiological study was published before, and actually this study in total will have 4 publications that have come from the data. So there was, as it was a real-life study, there was 103 nurses who were looking at overall originally 407 patients, and you can see through to the screening process they looked at 213 in total. But we're going to talk about the 64 patient subset for the Biatain Silicone group. What was unusual about this study was the only intervention that took place from our perspective was a small amount of product training and in-servicing on the use of the product itself. So no other training or other intervention was taking place. It was just reflecting their own clinical practice in that community setting, as I say, in Paris. So it looked at chronic and acute wounds. There was a baseline inclusion visit, follow-up visits, and obviously, and it was recorded photography and all the metrics along the way. But the wound care practice and the wound treatment was entirely chosen by the nurse themselves, depending on what wound they encountered at the time. So again, similar sort of age profile actually to the RCT that we showed earlier. Slightly different balance between male and female in this gender split. The French BMI is slightly less than the UK, which is probably a worrying trend. But also the medical history, about 78% of the patients were showing one or more factors that are causing delayed healing. And we'll talk about a little bit about that later. So these were the types of wounds that were actually found, which I think probably reflect most practice that I've seen before in published data. You've got a 58% split of chronic wounds to acute wounds, a large proportion of those chronic wounds being venous leg ulcers. But you'll see there's a wide variety of wounds treated in the community setting in Paris, and reflects a lot of the data I've also seen from the UK. Pressure injuries, diabetic foot, malignant wounds, and a higher proportion of traumatic wounds as well. So these were the wounds that the nurses encountered, and they used, obviously, Biatain Silicone. What they saw, again, reflects, I think, the real-world practice in that there was a lot of exudate pooling, and 69% of those wounds were showing exudate pooling. 52% had unhealthy wound edges, and 30% unhealthy peri-wound skin. But what's interesting was that 83% of the patients were enrolled due to treatment failure. So that was defined as either the wound was stagnant, it wasn't progressing as normal, it was non-healing. And what we see on the right-hand side is what we see frequently in many European markets as well, is this variation and unwarranted variation of care, in that Professor Hardy mentioned that earlier on, the challenge with establishing a differential diagnosis, in that in this patient group, 60% of the patients with pressure injuries were only receiving pressure relieving support. That 44% of those patients with venous or mixed leg ulcers were only receiving compression therapy, and that 50% of the diabetic foot ulcers were receiving offloading. So we see a lot of that unwarranted variation, as it's been described in the UK by Professor Guest in the Burden of Wound study, which is reflected, again, common practice in the community setting in France. So the results were really interesting, and in that within 22.5 days, 73% of the wounds were progressing towards healing. 25% had complete wound healing, and 48% were progressing towards wound healing. And again, photography was taken along the wounds, so you can see the before and after shots of some of those wound types. And again, as part of the study, the nurses and patients were surveyed, and we had really good outcomes to, the percentage reporting the wounds had improved. From the HCP's perspective, that was 88%, and from the patient's perspective, it was 85%. So they also reported the condition of the dressing when they removed it, which is, again, areas that of interest to us about wound conformability and how the dressing performs and conforms intimately into the wound bed. And you can see that when it was reported that it was 93% conformed closely to the wound bed on dressing removal.
Okay, thank you, Patty, for taking us through another really interesting study. For me, what I appreciate the most from this study is that they included the patient perspective and that the majority of the patients saw progression in their wound healing. I think, as many of us know in this room, getting patients to participate in care or be compliant in care, whatever terminology you prefer to use, for that is a struggle for us, right? It's a struggle to get them to do all of the holistic things that go into wound healing, not just the dressing piece. And so to have a dressing, a simple peel-in-place dressing that was able to get them the progress that they could see helps to encourage them to participate, and again is going to improve those healing outcomes that we want to see, especially in community care. So I really like that aspect of the study, and some really great photos as well. So this time we'll start with Jordan. What is your local experience with working with Biatain Silicone and its ability to conform to the wound bed?
Yeah, no, absolutely. I mean, just to go back to the study for a minute, I mean, I think we can all, appreciate there's nothing more frustrating than a wound that has either stalled or is not progressing to healing, right? And so, it is super frustrating, and so something that really speaks to me, and it's really fun because, how do I say this? It's really interesting when you try a different dressing, and then all of a sudden something, for some reason, it kickstarts the wound to heal. And I think that's where, it comes down to like thinking outside the box a little bit and trying something new. I mean, the awesome thing about the Biatain Silicone is that it conforms to the wound bed. It is so cool when you peel off that dressing and see it, that it's swelled up and has filled right in, and has been able to manage that exudate. And so with that, it also comes down to the peri-wound. I've had patients where we've had peri-wound maceration from the dressings and the protocols that we've been using, and then all of a sudden, for some reason, within a week or two, that peri-wound maceration is all gone. And it's nice to see how that absorbency and that management of the exudate was something that was so significant to help with wound healing, right? And so, it comes down to like, the conformability. I mean, I've had patients who have really expressed they're like it's a comfortable foam to sit on their skin, and really the itchiness is gone, because sometimes with that peri-wound maceration comes pruritus and comes discomfort and everything. And so with being able to manage that exudate, I've said that word a lot, haven't I? It's a matter of we're trying to create that perfect environment in the wound bed to allow it to heal itself, and it's been a really good experience for me and my community.
Well, most of the feedback I get is that it's very, very gentle for the skin. And I'm seeing a lot of sensitivities towards adhesive. And when I use or recommend the Biatain Silicone, usually the clients don't have issues. I've had clients or nurses reach out to me where a client just can't keep a dressing on, for more than a couple of hours. And once we switched on to the Biatain Silicone, I think it's stayed here. They never disrupted it. So really allowed healing to progress. And in long-term care, where I spent a long time, over a decade, so my heart's to those that are supporting long-term care. It's a very, very unique environment, especially when you're tasked with so many things throughout the day, dealing with different conflicts, managing your residents. a lot of your residents with responsive behaviors, it's not like you can sometimes get them to settle there, cut your contact layer, cover this, and wrap it up. If it's very bulky, especially with those with distorted cognitive insights, they don't understand the importance of having a dressing on, and they will rip it off, and then it's like a battle back and forth. And once you use the Biatain Silicone, they won't even notice it because it conforms so well. It's so gentle, and it can stay on a few days, and you just don't have to bother them. So that's actually one of my favorites. And especially when they're on blood thinners, they have sensitive skin. You should not be using adhesive tape. With the technology nowadays, adhesive tape should not be using to secure dressings. We're actually way past that. And then in community, because of the push of clients into ambulatory clinics, a lot of no-shows, a lot of non-adherence to routine dressing changes is what I see a lot. And we have to kind of partner up with the client, ensure that they can actively participate, especially if it's a site that they can dress. This reduces contamination, it reduces, visit frequencies. They can be, play a part, going back to the wound bed preparation paradigm. We have to look at those capabilities for that client. It shouldn't be a one-way street where we're just constantly delivering the service, especially if it's a maintenance or a non-healable wound.
Yeah, I just want to add, I love how Jason has mentioned the wound bed prep paradigm. I mean, that is probably the best evidence base that we have here in Canada. And we have to look at the patient-centered concerns. And is there something to help support that, right? And the patient has to be in this journey with us. We can't just force something upon them. And so to have them to be able to adhere to a dressing longer than a few hours is amazing. And I've seen that too, where some patients, they just cannot handle, whether it's an adhesive or another dressing, and being able to all of a sudden put them on, a Biatain Silicone, all of a sudden I don't hear from them for the 3 days that we're treating them. And, it's amazing to see the results. It's awesome, actually. It gives me goosebumps, to tell you the truth.
So are you guys seeing an increase then in self-care in your communities because of the simplicity of the dressing? Sometimes for me, when we were using multiple dressings, that was a deterrent from patients participating in their care because it was very complicated, or maybe they had poor dexterity or poor eyesight. Are you seeing an increase in participation in care now that you're using Biatain Silicone more frequently?
Yes, much more simpler, especially it's actually very user-friendly. It doesn't wrinkle, so even if they kind of misalign it, they can easily realign it. And it's less steps, so it's much more easier for them, much more efficient.
You know what? Our patients just like us so much. I'm just teasing. Yeah, absolutely. Yeah, I mean, patients are able to, if they're willing to, the hardest part about community care, and I think all the community care nurses can express this, is finding a time within this person's life that you can actually go out there and see them for however long they need us to be seen. So if we can give them that, autonomy and empower them to be able to say, hey, you can put this on, you can do it yourself. I'll see you in 1 week. It's easier to do a weekly dressing change or visit versus, every day or every second day. And so if we give them that power, to be able to change the dressing themselves, it goes a long way to create, something that they have control over. Because I think that's something, especially within the healthcare system, we see is that patients get very frustrated when they don't have control over their lives and their health aspects. And so by providing them something that's simple to use and easy to use, easy application, it gives them that autonomy back to their lives to say, yeah, I can go down to Tim Hortons and have a coffee. I don't have to, at 10 o'clock, I don't have to wait for the nurse to come at 10 to change my dressing, right? Just getting them back out into the community and their social to help with that part of their lives as well is good. So.
Yes, and we should not be doing daily dressings unless it's like a post-op wound or something that's exudating very heavily. With the advanced technology, we want to reduce the disruption of the wound bed with the daily dressing. So to avoid that, and going back to long-term care, For any of the nurses that are practicing that setting, I can guarantee if I look in your treatment cart, you have that same antimicrobial filler sitting there that is being used by all your residents on that floor. That is a no-no. That is a high risk for cross-contamination. I know a lot of you guys do it because we don't want to waste because we know resources are limited. But if I was a compliance inspector and I looked in there, I guarantee that dressing, that package is not dated when it's open, and you probably did not date who that resident's for. So we should not be doing that, because when I go into the homes to consult, I'm just seeing that one pair of scissors that's being used to cut off the previous dressing, to cut the contact layer, and oh my goodness, and it's like, where's the alcohol swabs? That's why I always bring extra scissors when I go in, because that is just, I'm a stickler for that. That's something that we can avoid. We just have to make it very simple.
Okay, thank you. So I guess I presented a snapshot of the evidence for both the RCT and the observational study, which is a combination of probably 4 years of work. So it was a major undertaking from ourselves, but we're delighted with the results. And it confirms a suspicion of what we've known in the past about the majority of wounds, and from audit data being up to 2 centimeters of depth. And now we have a potential solution which is easy to implement back in practice, of using a conforming silicone foam dressing instead of standard of care. So hopefully we provided you with some insights and some evidence that may help you back in your practice when you're back next week. I think we're going to move to some questions now.
Okay, a big thank you to Patty, Jason, and Jordan for their presentation. We do have plenty of time for questions. So for those in the audience, there's a couple of microphones on the floor, so please come on up and answer a question. And then we also have our virtual attendees as well. And I feel like there is some questions here, so hold on. Okay, our first question, can you speak to the ease of removability, especially as exudate decreases?
The ease of removability, so it's very gentle to really peel back the dressing, so it's not like something where you have to really irrigate. It's less trauma. I usually don't ever get skin tears when you're removing the Biatain Silicone. So, and there's usually never really have to use any skin prep, because sometimes skin prep can, cause interactions to the skin, and I'm seeing a lot of sensitivity reactions from skin prep. So we always say less is more.
Yeah, I would echo that as well. I mean, the silicone is so nice on the skin, but yeah, I understand where this question's coming from, because sometimes when you're on other dressings, you're peeling back, and if it's really a dry, flaky peri-wound skin, it can tear, right? And then you're starting from square one again. I have yet to experience that with any of the Biatain silicones that I've been using. It's very soft, it's very gentle. It's not as, I almost want to say, not as irritating to the skin.
What about as the exudate dries? Like, I know from using a lot of hydrofibers and alginates, as the exudate reduces, they kind of dry out and harden and are very difficult and painful to remove from a wound bed. Have you experienced that at all with Biatain Silicone, or does it just easily?
Yeah, no, I mean, I wouldn't, like, I guess the how I understand the question is, yeah, absolutely. Sometimes with other dressings, when it soaks up so quickly that all of a sudden it dries out the wound bed, which then, as Jason was saying, we were having to use like saline or something to re-soak it to peel off. And I have not yet experienced that. It soaks it up, it holds it in, and then the nice thing about that silicone is it just peels it off. It doesn't really leave any kind of crusting to the wound bed or the peri-wound skin.
I think the moisture balance is what makes this dressing stand out compare to most other dressings, and that's why I think we have less issues when we're removing it.
Okay, thank you. This is maybe a little bit similar. Does Biatain Silicone stick to the wound bed fragile edges like Mepilex?
I mean, for me, as we went back to that last question that was asked in the slides, it's the conformability, right? It will really, it's kind of cool. I think Coloplast calls it the 3D fit technology. It'll literally fill the wound bed to the contours of where it goes. And as I pulled it back or peeled it back, it does not stick to that wound edge whatsoever, and it really just conforms and really helps manage that exudate and manage that moisture management within the wound bed and the peri-wound skin.
Okay. Oh, do we have an audience? Yep.
Hi, can you hear me?
Yes.
Oh, good. I have a couple of questions. One of my questions is, with Biatain absorbing so much exudate, does it contribute any of that exudate and yucky stuff back to the wound bed?
I was going to say that sounds like a scientific question. No, so what they taught me about the foam when I took the education originally was the exudate comes in and then it gets locked into the foam. And so then it's not pushing anything back into the wound bed.
Yeah.
Thank you.
That's like the Reader's Digest version of what they told us.
Do you mean under weight bearing or compression, for example?
Well, that's mostly because I'm a chiropodist, so I'm looking at weight-bearing wounds all the time. So it kind of yes, does it squish any icky stuff back in? And my other question is, you've talked about not using tape, and that's great because I appreciate how hard tape can be on skin, but I have a hard time keeping a dressing in place because of the shearing forces that are at work when people are walking. So as they're walking, as they're propelling themselves and in their shoes, their feet are doing really weird things. So they'll come back with a dressing that looks like a scrunched up piece of paper. So have you found any ways to secure a dressing to the plantar aspect of a foot without using tape?
Do you have any experience?
Yeah, I think the most common thing we do is we like to wrap. We use a lot of conforming bandages. I sometimes find some of the mesh sometimes works, but I think you have to look at the footwear as well, especially when there's a wound, especially when you're a chiropodist and offloading is. But I think maybe teaching them to be able to self-manage or maybe doing dressing changes every other day or every 2 days, 3 days might make a big difference too, especially if they can reach it. Unless they're getting day to day, but they should not be getting daily wound care. I don't think that's conducive.
Yeah, I mean, I just wrapping it with some sort of like light compression if they're able to handle. That's where I found to really secure it well. Sometimes with the foot you do have to use tape. I mean, it is a little bit of a tougher skin. Like usually when we're saying don't tape, I'm looking at like pressure injuries to the coccyx, lower leg, venous ulcers. That's where the skin is very thin. The back of the heel, the plantar aspect of the foot, the skin usually can handle a little bit more. But really it's a compression sleeve or a compression like wrap in a sense is where I've found most success to slipping it. But also, you're looking at them using their footwear, right? They're putting it in, pulling it out. I've seen it too where we take off the shoe where all of a sudden it's rolled up like a scroll. And I'm like, oh, great, we're going to add another point of pressure here. And so, for me, it's like, okay, you're looking at that diabetic foot ulcer. It's like, look at the cause, right? Well, it's the footwear. And, when we're looking at, other aspects of care, is there any possible way for this person to be offloaded? Whether that's, putting them in crutches, a knee scooter, something that will help them, offload that foot as much as possible. Sometimes we can put the best dressing on, but if we're not treating the cause and correcting the cause, with also addressing patient-centered concerns, then it's not going to work. I mean, I'm working with a guy right now who's a welder, and it's just like, hey, you've got to get off this foot. He's like, all right, once I'm done this job I'm at, I'll take 3 weeks off of work, and then we'll start working at this. And it's also trying to meet the patients where they're at, because if they're not going to properly offload, then it's going to be very difficult to get anything to heal on that bottom of the foot. Does that make sense?
It makes sense.
Yeah.
So recently we've started using a product, well, we've been using Coban and similar products to retain dressings to the plantar sole. So we're avoiding tape and it's working quite well, as long as it doesn't irritate the skin. So I just thought I wanted to share that with the room, so.
Yeah, no, that's awesome.
Thanks.
Thank you.
Yeah, thank you very much. Oh, are you going to? Oh, go to the mic so we can all hear you.
Biatain has one product which has ibuprofen. Correct me if I'm wrong.
Yes.
Yes, we do have a dressing called Biatain IBU that does
Yeah.
contain ibuprofen within
So-
the dressing. Yeah.
Is it safe to use on pyodermal gangrenosum? Because they have pain for that particular dressing.
Have any of you used that on any of those, that type of wound?
So for Biatain IBU, you need to look at moisture.
Okay.
That's key in order to fully activate it. So I think it's more of trial error. I've had clients who loved it, and I have clients that says it does nothing. But is it safe to use? As long as you're not traumatizing, especially when you're removing it, it's usually pretty gentle when you peel off.
Yeah,
I don't think the
I know.
exudate usually doesn't stick, doesn't really dry up and hard. So, yeah.
How about for the skin tear that is very like severe, like it has ecchymosis, erythema around it?
Are you talking about the IBU or talking about the Biatain Silicone?
Oh, just the silicone. Should I put
It's great. It's amazing for
Should-
skin tears.
Should I put moisture on it? Bactigrass?
It depends. It depends on the degree of loss in terms of is it partial, full thickness. If it's just a skin tear, usually if you leave it on for a few days, it's quite okay. Unless you have to look at the wound bed. Is there signs of local infection? Look at what the exudate is.
I tried to one of my ICU patients, the one with the eyebrow, and she said it helps on her pain. So that's why I asked.
Oh, that's good to hear.
Yeah, that's good to hear. Okay, I've got a couple more questions online. Is there any use for this with arterial or ischemic wounds? Would the dressing have to be replaced often to avoid overly drying out the wound? Have either of you used it on arterial or ischemic?
I mean, usually with arterial or ischemic wounds, there's no blood flow. It's usually a dry eschar cap. I'd hope that they would be seen vascular before we put a dressing like that on. Again, Jason, it depends, right? Normally, you're not looking at moist wound care management at that point. You're looking at dry wound care management where this type of dressing probably isn't appropriate for that type of wound. Because I honestly haven't used it on that because I normally wouldn't use that on that type of wound.
Yeah, it definitely can be used, especially if it's promoting comfort, because with the ischemic wounds, doing the wound care, it's really painful. And if it's actually, you have to look at what your wound care goals are. And if at this time it's kind of maintenance or it's progressing to non-healable without some sort of arterial, surgical intervention, then I think it's something that surely can be used.
Okay, perfect. Is there any contraindications to using this product?
Patty?
Not that I know of. I can check in the IFU, but
Yeah.
I don't have to hand. But as far as I know, no.
No, I think it would really just come down to sensitivities. I mean, like there's always somebody out there who might be sensitive to maybe the adhesive or to silicone. And so, of course, if that's the case, please avoid it in those patients. Biatain silicone is really best for non-infected wounds. And then we do have products for infected wounds. So if you are seeing those local signs and symptoms, we have a conforming dressing that can help treat that. Just use caution. If it's an infected wound, you'll want to treat the infection. But this product is really gentle and safe for the majority of wounds that are non-infected and highly exudating. So, and as we heard, it's quite gentle and comfortable for patients to wear.
Yes, we have a question.
Thank you.
I haven't used the product before, so I just wanted to know, you
come
spoke
in?
about conformability. What I hear is vertical conformability. How is it for horizontal, so for undermining? And then if it does fill in a little bit of undermining, how much of it? Does my question make sense?
Yes, I think you're asking conformability and will it conform in undermined areas. Yeah, so it's sort of more vertical. It conforms down to the wound bed. It's not going to expand into any undermining areas, so we always recommend using a filler for undermining or wounds that are greater than 2 centimeters deep. But for those shallow wounds that are 2 centimeters deep or less and no undermining, no tunneling, it will conform down to that wound bed and then absorbs the exudate vertically into it. Anything to add?
No.
Yeah.
You did great.
Okay. All right. One more from the audience.
So I work in an outpatient clinic, so being able to shower is super important to a lot of our clients. Will they ruin their dressing by showering with something like this?
No, it is waterproof. I mean, obviously, if there's a wrinkle in the dressing or anything, I don't know if I should say this out loud, but I had a patient say, I can take a bath in this. I'm like, please don't bathe in this. So, yeah. Showering, absolutely. Please shower. Please encourage your patients to shower and proper hygiene.
Yeah, I think it might also come down to location. So if it is a wound on the foot and they're showering and it's, submersed in water, of course, that's going to loosen the adhesive and it will probably come off. But if for anything lower leg and body, showering is fine because it is waterproof. And I actually used our Biatain Silicone AG on my colleague a few years ago, and she showered twice a day because she was a gym rat. She just loved going to the gym, and so she would shower twice a day, and it stayed on for a week. So, as long as you've got like those smooth surfaces and you don't have any kinks or any channels for water to come through and penetrate, it should hold up during a shower.
Okay, thanks.
I know every wound is different, but is there a standardized time frame between dressing changes, or is there an indication on the dressing itself that lets us know when to change it?
In the immortal words of our good friend Dr. Kevin Wu, it depends.
Yeah. Well, is there a standardized time that you have found throughout studies?
I think the instructions for use indicate 7 days. But it's very much dependent on the level of exudate, the type of wound, anatomical location as well.
Mm-hmm. Thanks.
Yeah, it's
Awesome
really
question,
difficult for us to provide like a standard, because every patient's different, right, and has different amount of exudates. And so we really generally recommend it can be worn up to 7 days. Depends on the amount of exudate, the condition of the dressing. We know with silicones, as we heard with our previous person who came up and questioned, that they can sometimes roll if they're on the foot and things like that. So that's all going to go into your decision to when to change the dressing. But I mean, the fluid handling capacity is quite high, and you can come see us by the booth later and check out some of our resources, because we do have a when to change guide, and it shows, if there's light shadowing or strike through in the dressing, it can stay on longer. But as the dressing kind of reaches capacity, you'll see darker shadowing strike through, and we generally tend to recommend changing when the strike through reaches about 75% of the wound surface, or if the exudate looks like it's coming towards the edge of the foam. If it comes within 1 centimeter of the foam, again, we would recommend to change. But again, it's going to be really patient specific and based on your assessments and what you're finding with the condition of the wound. Thank you.
You mentioned about the filler material in case there was undermining in the wound. And I was just wondering, like the Biatain Coloplast dressing can be used for at least, it can be left intact for at least a week, one of the slides. And but when we put these things together, I was just wondering if the use of filler material would impact how long you actually keep the Biatain dressing on the patient. Is there a specific filler material you recommend, or you have a product with Coloplast?
I'm not sure I'm quite understanding the question. Did you?
So if I understand correctly, it's usually when we're using a packing material, there's always kind of a standard of how long that packing material can be left in the wound bed. Where with the Biatain Silicone, we can leave it up to 7 days. But with that packing material, does that change the length of time of how long? And do you have a recommendation of what packing material we could use?
Well, I mean, if you are using packing material, you can. It would depend on that packing material. So each, depending on what company you're using, they have recommendations. So if you're using a product that has a 3-day wear time, of course you're going to have to change it every 3 days. But we, with Coloplast, we have Biatain alginate, we have Biatain fiber, so hydrofibers, alginates, things like that. Again, our products have a 7-day wear time, so you could get up to 7 days while using those products. But yeah, you'd have to check with the individual company of the filler that you're working with and go with their manufacturer recommendations.
I was just thinking like this might be an opportunity for Coloplast to develop a product which can be used as a packing material which can be left for 7 days, in other words. That is one opportunity I think I can see there. And another question also was about the kind of cleansing materials, the compatibility of cleansing materials, wound cleansing agents with the dressing itself. How would that, are there any specific studies done to determine which cleansing material works best? Or we are just going by the wound characteristics and deciding this cleansing material, right?
Yeah. So we haven't done any like RCT studies with comparing different cleansing solutions with our product. But from a manufacturer standpoint, it's safe to use saline, sterile water, potable tap water to cleanse the wound. We do recommend if you're using oxidizing solutions, so things like hypochlorous acid, that could affect the integrity of the foam. So you would need to, be careful with using that. Maybe you might need to rinse it afterwards or pat it dry just so that solution doesn't break down the foam. But yeah, you could use saline, sterile water, potable tap water are safe to use with the dressing.
Yeah, thanks for that clarification, because that's the last thing we want for any kind of foam material actually breaking down and disintegrating into the wound and causing more harm than benefit.
Yeah.
Thank you.
Yeah, thank you. Are we still? Oh, I think we have time for maybe one more question.
I think we have a question coming to the mic.
Oh, okay, go ahead.
Hi, good morning. I'm just wondering for Biatain IBU, if a patient is allergic to ibuprofen, is that advisable to use? And the second question is also in regards to Biatain IBU, when do we apply it? I know that there are wounds that are painful, but there are also wound beds that are most probably with slough for that reason, and it's painful. So is it advisable to use Biatain IBU when you actually do not have a granulation tissue bed, wound bed?
Okay, so from the allergy perspective, you have to see what is the reaction, right? In terms of if they're allergic to an NSAID, right? So, but it's very, very minimal in terms of the how the medication is released in the dressing. So you have to see what are you trying to achieve with the pain management on that part.
Yeah, I do understand that IBU penetrates very minimally from the IBU ibuprofen.
Mm-hmm.
So basically, it's the advice is to use ibuprofen for a patient who's allergic to ibuprofen. Sorry, Biatain IBU for a patient who's allergic to ibuprofen with caution.
Mm-hmm.
Okay, and then the next question is the use of IBU, Biatain IBU on a wound bed that is not 100% granulation.
Not 100% granulation, not really concerns as long as there's enough moisture to activate it. That's the key part.
Yeah, absolutely. You need enough exudate or moisture to be able to activate that IBU, because if you put it on a dry wound, it can't transfer into the skin as well. So, yeah.
Okay, thank you.
Okay.
You're welcome.
Thank you. So that's it for us. I want to again thank you to Patty, Jason, and Jordan for presenting today. I invite all of you to stop by the Coloplast booth later today. Our guest speakers will be in attendance at the booth, and so you can ask more questions about the study or about Biatain Silicone and our other wound care products from Coloplast. And please remember to evaluate today's session. You can find the link on the VFairs platform through the app. And so thank you very much for your attention today.